Spasibo большое. And we're now going to move to the next speaker, which is George Behrens, who works at the University Hospital in Hannover. George is also the past chair of the comorbidity section within the EX guidelines. Is moving on to the new chair of the guidelines altogether. So very good to talk here on the aspects of comorbidity.
Thank you very much, dear Chairman and esteemed colleagues. Thank you for inviting me. And after I roughly counted 200 slides, it's just me in between you and the lunch break that we have in half an hour. But I fear I have to add a few more slides on very top. I called it hit hard and early in terms of comorbidities in HIV infection, which is a term that was used or introduced, I think, by David Ho many years ago in regard to HIV treatment. At that time, we, or some believed, to do a lot would be a good thing. Then we stopped this and waited, and now we're back to hit hard and early to treat HIV infection. I'm still not sure in regards to comorbidities and some other conditions in our patients, how engaged and how enthusiastic we should be, and this is one of the big challenges, I think, that we face. So let's start with the good things, because what we achieve and what we can achieve is a good thing to start with. If we have patients fully suppressed with viral replication, they have good CD4 cell counts, their life expectancies, and this is data from the UK, is very good. They expect, if they are diagnosed at a certain age, they can turn 80 and older, probably even better than the non-HIV infected population, but I think this is just pure calculation, we don't know. If you've got less CD4 cells, if the immune reconstitution is less good, the perspective is a bit less good. It's still, of course, improving and well, but immunological non-responders with low CD4 cell counts, despite virus suppression, are not as good as others. Things get worse, of course, if viral suppression is not really achieved. So if there is, for whatever reason, incomplete virus suppression, the prognosis is worse. We had the question in terms of sex and gender this morning already. It is basically the same for female patients. And we got better over time. Patients that were treated over the last decades benefited from two things. We got better treatments and we started earlier. And that has an improvement also here in the life expectancy as compared to controls. This is data from the Danish cohorts. And there's very confirming results from different countries in the world. So the good thing is we turn our patients into elderly patients. We make them healthy, but it's a bit bizarre to become sick again because then they get other diseases. But that's a good thing. The average age in the cohorts is increasing as a consequence of the success of HIV treatment. And we are right here in the middle, and that's what you can see in many countries across Europe and many other countries as well. Half of our patients are above 50 years of age. And the prospect, of course, is clearly going up. In 10 years, that will be another 25% on top. And that is much quicker rising than in control populations of non-HIV infected people. And as we get older, we accumulate other conditions, diseases and complications, and that's the same as what we would expect in non-HIV infected patients. There is a raise in patients that are older with HIV infection of cardiovascular disease, chronic kidney disease, of diabetes and other issues. Some of these diabetes incidences are slightly flattening because the treatments that we're using against HIV induce less diabetes, but our patients still get older, and we know that diabetes is a risk factor as you get older, and cancer, of course, as well. One can count all these numbers and go one step further and try to have a look into the future. This is done by a group in the Netherlands, and they calculated over the next years, like modeling, but modeling has issues, we've heard this morning. They calculated the number of different comorbidities people will have in the future. And what you can see is what we see here in black and in gray, the proportion of patients having not only one comorbidity, but accumulating multiple of them will increase. There will be mainly cardiovascular disease, diabetes, and malignancies. And they calculate that in 10 years from now, in their population at least, a significant proportion of patients will have cardiovascular disease. I'm not absolutely sure about these cure numbers and whether that's really crystal clear, but the trend will be we've got to face that more of our patients will have cardiovascular disease and the resulting complications. Now, we've heard about this as well this morning, 1990, and people have added, once we have this success, you can go up to 95, 95, 95. But there is also another idea that we need not only to look for the sheer numbers of viral loads and CD4 cell counts, but also that we keep our patients healthy so that they can get old and don't suffer from other diseases, and that life quality of life and life expectancy go hand in hand. And one of the results of all these concerns is also that, again, the European guidelines are growing and growing. Last round of revisions 2 years ago, we included new chapters about new conditions which we haven't considered before, but where there is evidence, at least in some cohorts, that patients with HIV infection have also increased risk for non-alcoholic fatty liver disease, for chronic obstructive disease in the lungs, because there is much more people smoking in the cohorts with HIV infection, and other specific conditions as well. So we've got to expect to deal with this. And it's very challenging to find good guidance on this at times. What are the reasons for these comorbidities? One concept we've heard this morning is related to inflammation. And being an immunologist myself, I, of course, am interested in this concept as well. The idea is that HIV replication itself causes immune stimulation, a loss of immune regulatory cells, microbial translocation. And if we start treatment, we can offset some of these effects, we can reduce some of the effects, but we can't stop them completely because there is a remaining inflammation, and then these patients that we have will have traditional risk factors. They may have genetic risk factors for diabetes, they may have genetic risk factors for cardiovascular disease, or they have modifiable risk factors like smoking or other behavioral issues. And that's the concept, increases and translate into clinical events and comorbidities that we should look after. If I want to put it into simpler words and pictures, I would say if a patient without treatment, if I see that one, there's a lot of virus and there's a lot of inflammation. If I start treatment, I reduce the amount of virus in the body, and I reduce also the inflammation, but the inflammation is not zero. Even in these rare people which are able to control viral replication without treatment, it seems that there is a bit more inflammation in these ones as compared to HIV-negative controls. But as usually in life, it depends on what you compare to what. So very often, HIV-negative people are used as controls, and that can be for good reasons, but it can also cause some challenges, as we will see. There is general agreement that the risk for cardiovascular disease in HIV patients is about twice as high as in control groups. This is across different cohorts being described. The idea, again, is that this is a result from traditional risk factors, and on top, the additive effect of inflammatory effects and partially also treatment effects over the last years. You know that some of the drugs that we use may be associated to high risk leading to cardiovascular events as well. This could also be the reason that the risk calculators that some people use to predict if an HIV patient is at risk for cardiovascular disease are not perfect, because they're derived from non-HIV infected people and then translated into the HIV positive population. And thereby, you see the predicted rate is slightly less than the observed one rate in the HIV population. That would be one of the explanations. Inflammation is a term that is not really coined, so we don't know what inflammation really means. There's hundreds of different surrogate markers. This is yet another way to make it very nice for presentations as well. This is what we call a PET scan, a positive emission tomography, where these people just look where there is more glucose metabolism as a reflection of inflammation. They compared HIV negative and HIV infected patients and looked in different regions around the heart. This is the aorta. And what they were able to show and to demonstrate, there is more inflammation around the aorta as compared to HIV negative patients. Okay, that by some experts is also being seen because atherosclerosis is an inflammatory process as a surrogate for more inflammatory processes at other vessels and arteria. Some experts doubt that this is easy to translate, but it's an accepted, more or less accepted effect. And these aortic inflammation also correlate to surrogates we've seen this morning, several others like monocytic inflammation in the blood. Now, one question would be, what would now HIV treatment has an effect on this inflammation? And that's what the researchers did and published then slightly a couple of years later. So they started treatment in these patients and take out the effect of HIV. And the first thing that you can see is, yes, it seems, well, it's more reddish and it's more yellow. And it's here in the lymph nodes, baseline, very inflammatory, and it gets better upon treatment. And if we quantify this in a small group of patients, you see the activity of inflammation in the lymph node goes down. That makes sense. We treat HIV and the inflammation and the replication goes down. But in the aorta, you see, it's even going up. That doesn't make really sense. It just reflects that inflammation and things, depending on where we measure, can be very diverse and very different. So not every intervention that measures a decline in some place probably reflects a decline in another place in the body. Many different groups have shown that in HIV-infected patients, there's lots of inflammatory markers, either on cells or in the blood, being increased and raised, as compared to healthy donors, which are easy to take from blood donor banks or other situations. Another group from the Netherlands asked the question, we should be closer to this sort of patient group and have people so men having sex with men, but not having an HIV infection, but having very similar background risk for also sexually transmitted diseases. And what turned out of these studies is that even these ones, T-cell activation and exhaustion, monocytic activation markers and others, are increased already. So inflammation, systemic inflammation is, I'm pretty sure, an effect of HIV, but there could be other effects coming on top of it, which at least partially explain some of the events that we see in our patients. Lots of different surrogate markers have been established, not only to be different among different groups, but also being used to predict mortality during suppressive heart. Some of them seem to be very good. Some of them have been used in algorithm, but hardly anyone in the world uses them in clinical practice as for now. So we can describe all these effects, we can measure all these. They're not always easy to measure, but little has been used to translate and to help us in clinical decision making beyond probably CRP use. At least that's what we do. The challenge for me as an immunologist is to understand what inflammation is and what it's not. So this is a picture from Paul Cézanne, and you can arguably say it looks nice. It's certainly very expensive. But on another day, he took the same scene and did a different paint. He uses other colors. So if cytokines were colors, what would be the right mixture? What is inflammation? What is it too much from this if we probably haven't measured what's counterbalancing that situation at the same moment? To be honest, I like this much better, but I'm not sure. Many others would say I like the right situation better than the other. So what is inflammation? And I think this is one of the challenges that we're still facing. We know for sure that the classical risk factors are prevalent in our patients, and that if we can modify them, that can have, or that this will have a beneficial effect on the outcomes. We see that previous cardiovascular risk factor is something dominating the overall risk in patients that develop cardiovascular disease and HIV infection. And if we can achieve and help patients to stop smoking, for instance, then their risk for myocardial infarction over the years will go down. It won't stop immediately, of course, but over the time, as in non-HIV infected patients, will also normalize and decline. So it's worth doing all these approaches. Others have worked and have discussed other approaches because they fear that drugs like the tenofovir, TDF formulation, or abacavir, which all raise caution in some patients with comorbidities or organ dysfunction, should be avoided and replaced, in that TAF was developed or others are developing strategies avoiding abacavir, for instance. All this can help, and all this will help to improve our treatment, and will be discussed probably in other sessions here. But we know, despite HIV treatment, that some of the advantage or the progress of some of the conditions are more rapid in HIV patients than in controls. The decline in glomerular filtration rate in patients with HIV infection is faster, irrespective of treatment, which could be related to the viral infection, and particularly it's related to ethnicity. In Black people, this decline is usually much faster. We know that some of the drugs that we use over a long time, that some are listed here, tenofovir, TDF, atazanavir, and booster PIs, over the long term increase the risk for renal impairment, irrespective, or at least it was tried to control from other factors in adjusted models. And that's why some people favor not using these drugs, at least in patient groups at risk for renal dysfunction. But one of the biggest challenges is always, should we be proactive? Should we maintenance our HIV treatment in every patient? Should we look every time we see him and reconsider everything? Or should we just be reactive and say, okay, we watch the EGFR, we can make urine sticks and look for proteinuria. And once we see changes, it's always time to react, and we will achieve and maintain them, and it's enough. Maybe, maybe not. This is data from a case series, very small, where it was looked in patients with TDF-associated proximal tumulopathy, which is a real severe side effect, potential side effect of the drug. And they had EGFR levels before start of treatment, then they had this complication, and even after stop of TDF, things got better, but they didn't normalize. But it's tricky to adjust how much normal decline these patients would have developed anyway. if we look into more recent data and ask the question of which patient really benefits from a switch away from TDF to the new formulation like TAF, then one could see really shown, this is data from the Swiss cohort, it's only a benefit if you measure the eGFR only in patients that go down with the eGFR of less than 50. If you then switch away from TDF, either to TAF or to another drug or combination, then still you see an improvement and a regain in that remaining function, which is not bad. At the same time, these maintenance or these reactions can have other, I wouldn't say detrimental effects, but other side effects as well, because we know that TDF has a slight lipid lowering effect. So if we take out TDF in some patients and switch to TAF, then in some of these patients, not many, but in some, the cholesterol levels or the LDL levels may increase. While that's not necessarily a major concern in many of our patients, in some it can be an effect. And on a larger scale, people are already discussing how to balance to protect the kidney, but then also to slightly over time increase a cardiovascular risk factor, a situation that you support by this. Other organs, like the bones, might be affected as well. We know for many years that the rate of fractures, osteoporotic fractures, particularly in HIV-infected patients, increases over time and increases with age, irrespective of the fracture that you look at. If you sum them all up, you've got this increase over time and over age, I must say, and there is evidence from different control groups, which are not included usually in the studies, but are historic controls, that this is higher than the numbers that you would expect from normal or non-infected populations. I said, and many others over the last years, but I don't see all these fractures and I don't have these concerns, and that's why I want to highlight another factor. Osteopenia and osteoporosis is something that we can measure and assess. One assessment is by quantifying this in T-scores and comparing it. In order to have fractures, not only weakened bones, but other factors need to rejoin the figure. For any given T-score which is too low, you see that the rate of fractures only increases as people get older. Factors that contribute to fall, like weakness, sarcopenia, issues with visual issues, other things, only increase then the incidence of fractures over time. And the prevalence of osteopenia and osteoporosis, even in patients here living with HIV, which are less than 50 years of age, is relatively high, with about 30% having osteopenia and about 15% having osteoporosis. And of course, the question is, do they need specific care? Should we regularly recommend vitamin D supplementation, exercise, and other things? Factors which are associated with osteopenia were, and that's what we know from outside HIV as well, the lower the BMI is, the higher is the risk for osteopenia. And interestingly, treatment of HIV infection reduced the risk for osteopenia, at least in the first 3 years, because uncontrolled HIV infection and, I add, inflammation contributes to a negative turnover. So to start HIV treatment is something good for the bone health, but then others might argue, what if in the long term tenofovir exposure then eats up all these effects and leads to a net rather detrimental effect? We did another study in terms of lung function and obstruction and found that many of our patients have airway obstruction after, which is persistent after beta agonist, and have symptoms. So the prevalence of COPD, chronic obstructive pulmonary disease, is about 8%. But almost the same amount of patient has obstruction, which is persistent, but don't report symptoms. Maybe they don't report them yet because they're also heavy smokers, just 10 years less. Question now is, do they need specific care? Would they benefit more from stopping smoking? Do we have other measures or things that we can advise them in order not to go into this group and to prevent disease progression? That's something we don't know either in HIV nor outside HIV medicine. And yet others for years now work on concepts to combine this idea of multimorbidity, multiple comorbidities, to concept this into a frailty phenotype, which might be used to characterize these patients and to do science in cohort studies. But many of us are a bit hesitating in that they say, these effects or these factors I don't expect to see in 50-year-old HIV-infected patients. Others would argue that a patient which presents late and has AIDS-defining event can easily be scored as being very frail, but a year later upon treatment, he's perfectly back at work, everything is fine. So a lot of people are hesitating to use these frailty concept in HIV medicine in clinical daily routine. But if we do it in bigger cohorts and look for the age of the patients and the duration of HIV infection, then we've got a high prevalence of frailty despite effective treatment, which is several times fold higher than non-HIV infected patients. Is it just the sum of the individual things, hypertension, diabetes, and others, or is it synergistic? Is that combination even worse than just the single parts? Mark has talked just about one cancer type, but what we observe, and this is at the very end of the presentation, that the non-AIDS defining cancers are increasing in our patient population as well. And that's what we have to expect, obviously. The older we get, the higher we have a risk for non-AIDS defining cancers, which means, yes, we have to consider them in differential diagnosis, not the classical AIDS defining cancers only, but this is getting more and more because more and more patients are getting older. Other cohorts confirm the same. DAD cohort, the time here, 1990 to 2000, causal deaths, and then here later on. Overall, the death rate declines. HIV treatment saves people lives, but the proportion of people that die more and more of cancer. So that's one of the developments we have to expect. What I think is a challenge beyond the clinical definitions and the algorithms and the questions how to best do prevention. One of the challenges is how to get things organized, and that is a question that's very different in very different countries across the world. The classical view is that HIV specialists look after HIV therapy and monitoring, probably also have the job to do the treatment and the monitoring for comorbidities, among many other things. But as all these other conditions also develop, get new treatments, new algorithms, new developments in science and clinical recommendations, things become more complicated. And who's taking care? Who's organizing it? What are the infectious disease specialists that know how to prevent cardiovascular events in the long term, or to do diabetes treatment? Is that a teamwork? Is that organized locally? Is that on a national basis? This is something that is very important to be developed because these patients will increase in numbers. Comorbidities, I think, are increasingly important. Which comorbidities are the really most important one is something that we discuss when we develop all these guidelines heavily and intensively in the telephone conferences. But we hope that the guidelines really help to deal in daily clinical routine. My belief is that individualized therapy becomes more important for patients to deal with all these comorbidities, and probably less important for the HIV treatment, because we have achieved a perfect level almost. And there is still a lot of need really to give us guidance on how important some of these comorbidities are, because we don't have really good trials with clinical endpoints. And I fear that's one of the challenges of the future as well. If we split up HIV treatment in an early phase and in a later phase, then I think the early phase is very much dominated from HIV treatment. Then it goes over into long-term health and screening and prevention of comorbidities. But there's also a shift. Maybe the doctor becomes or is very important in the early phase, but we need also to consider that patients become important and should contribute to what we are working on in the long term, which is to stop comorbidities, to work on the modifiable risk factors, and to get the patients on board really to enable them to have a long and healthy life, which then would add yet another 90 onto the table. Maybe they become 90 years of age at the very end. Thank you very much.
Spasiba. Questions? I have one question with regard to the LDL patients. I would absolutely agree that the amount of cardiovascular events is increasing. So the patients come back after a myocardial infarction, and the new target is less than 70 milligrams per deciliter LDL. And the patients who previously had TDF, that's also impossible to do. So what would be your recommendation for that? Is a statin alone, or would you revert even back to TDF?
So I agree to what we're describing. In some patients, the LDL might raise not just a little thing, but up to, another 30, another 50 in a few patients. And if there is a specific risk constellation, I would balance it, and I would say, yes, why not using TDF lipid lowering effect? I'm sure there will never be a study to confirm that this is preventing anything, but if one looks onto the goal to achieve these 70 milligram per deciliter, then this would be one way of doing it. So I've put back a few patients on TDF. Sorry if I'm not using this.
Георгий, скажите, пожалуйста, вот ваше отношение к профилактике многих заболеваний, какое значение пациентам аспирина? Но мы убираем нескольких зависей. Воспаление, профилактика сердечно-сосудистых заболеваний, тоже говорим профилактика рака. Ну а если сочетать со статинами, тут мы перекрываем много профилактических вопросов. Какого отношения ваше к современной рекомендации?
So what you're referring to is aspirin or lipid lowering drug, or a combination, or what people call the polypill. And I've seen in the media the first data. There was a huge study. I haven't seen the primary data on that, when a polypill was given to non-HIV infected patients. And there was beneficial effects on cardiovascular events. Some argue with aspirin on colon cancers and others. The question is always in prevention. The idea in principle could be good, but we need to have good studies really to show that we achieve the endpoints that we want to achieve, prevention of outcomes, not on the cost of other complications like bleeding complications or others. And some of these need to be balanced. But the discussion of using a combinational pill like aspirin or something else on top in HIV patients is ongoing. There's a huge study going on to show the prevention of clinical endpoints with a new lipid-lowering drug. And I'm sure that this will be pursued and will be continued over the last years, because these patients will be with us for the next 30 years. We'll have the same question, and it's obvious to do it in patients with more inflammatory background conditions like rheumatoid arthritis or HIV patients.
Great. Any more questions? If not, it's lunchtime.
Oh. One more question, and I'll promise to use the microphone for the translator.
Огромное спасибо за ваш доклад. У меня такой вопрос. Мы провели в Санкт-Петербурге небольшое исследование, и у нас получилось только у 13% наших ВИЧ-инфицированных нормальная концентрация витамина D. Значит, вопрос. Как мы должны назначать этот витамин D? Всем ли подряд? Это курсами или постоянно? Либо мы должны еще смотреть на схему, которую получаем.
That goes into, this is a core question which is debated in many countries across Europe and the Northern American continent as well. So I'm not surprised that you have high rates of vitamin D deficiency. That's what you have to expect here. I've found a very simple solution. For us, measurement of vitamin D levels is as costly as buying vitamin D supplementation for once a year. So I don't measure vitamin D anymore in my patients. I just recommend them, if they want to do something good for them and it's relatively cheap, they should buy and get some vitamin D. And either take 10,000 once a week or 20,000. I'll take 20,000 once every 2 weeks if I don't forget it. Oh, where's that? Everything okay? So there we go. I think she's okay. Okay. So I think I'm personally very generous in advising that patients should take it. I'm not checking it, I'm not controlling it, but it's one of the big questions. There's very little evidence that we prevent clinical events with pure vitamin D supplementation. It's just an idea of maintaining bone health. But all the big studies that showed or aimed to show meaningful clinical event prevention didn't really work. But in patients with tuberculosis co-infections, I would be more generous and say there is evidence also to say it may strengthen the immune response. It's a beneficial thing, but it's an individual basis. Okay, thank you.
All right, thank you very much. Enjoy your lunch.